Okay, ladies and gentlemen, good afternoon and welcome to Staffordshire Health and Wellbeing Board today, Thursday the 7th of September in the Oak Room. So welcome everyone. For those that don't know me, and I think most of you do, I'm Mark Sutton. I'm a Cabinet Member for Children and Young People here in Staffordshire and Chairman of this board. So we'll move swiftly on to the first item on the agenda, which is the normal welcome and routine items. And if we could have apologies, please, Liam.
Thank you, Chair. I've received apologies from Elliot Sharrard-Williams, Ian Reid and Claire McIver. Thank
you very much for that. Next item, do we have any declarations of interest? Okay, that's a big no, in which case we'll move on to the minutes of the previous meeting, which are attached, came out. Does anyone have any matters that for clarification or correction, or actually any matters arising at all? Okay, if that's no, I'll take those as read then. Thank you very much for that. And then questions from the public. Okay, if there's no questions from the public then, we'll move on to item 2, which is dealing with one of our 4 board priorities, which we're taking in order at each board. So today we're joined by Natasha and Nicola, you're doing it as well, are you? And it's Health in Early Life Priority Progress Update. So I think you've got a presentation, haven't you? So over to yourselves.
Good afternoon, everyone. So I will take you through a couple of slides, if that's okay. So you will all hopefully remember that this time last year you set a priority around health and early life, and the focus of that was around achieving better outcomes in pregnancy and infancy, with a particular focus on infant mortality. So I'm going to talk to you particularly about that priority today. We have included a report in the pack which is broader than that though. It does look at both the Children and Young People's Framework, which has been developed across the integrated care system, and it does also talk about co-production. So we will provide an opportunity for you to ask questions on those 2 areas at the end, if that's okay with you. And the reason for doing that is because actually we think that although children and young people and making sure that they have a successful and happy life is important, we do think that it's broader than just infant mortality, and hopefully today's presentation will explain why. So some of you might remember this from when you identified it as a priority, but Staffordshire's rate of infant mortality is above our statistical neighbours. Not all of them, but some of them, and it's worse than we'd want it to be. So I'm just going to talk you through a bit more around the data, why that is the case, and then a bit about the work that we're doing as a partnership to try and rectify that. So this is a long list. Apologies if you can't see it. You can see Staffordshire is towards the bottom on the West Midlands, but given our relative level of affluence compared to our kind of regional neighbours, that they're not sometimes the best comparator. When you look at our statistical neighbours in terms of areas that compare to us, I think we're about 3rd from bottom. So again, that kind of gives you an indication of where we are. So comparatively better than other people in the West Midlands, kind of mid-table really. There are 2 components to infant mortality. So infant mortality covers a broad age range really. So there's the neonatal component, so for those children who unfortunately die while they're in the neonatal phase, so they're in hospital, and for those that die postnatally, so when they get home. So we've included the 2 figures there. So you can see that Staffordshire in terms of neonatal is 4.3, and actually that is worse than we would like it to be. But when it comes to past the neonatal phase, actually we're much better. So you can see there that Staffordshire's rate is much better. But generally speaking, infant mortality is a kind of symptom or a sign of the general population. So you do want to be interested in how well we perform at it, because actually it does show you a number of different factors, and some of those relate to the socio-economic factors of the area in which you live. So that's why it's probably quite critical. I've given you some information within the presentation slides, which we'll send out, which do provide a bit of a breakdown in terms of how it looks across the different districts. So you can see there that Cannock, East Staffs and Newcastle are the highest area, but the rate as a proportion of the total children or child population is very, very low. So it's not even 1% in the highest district, so it is a small number of deaths. Now, there is a lag in the data, so the most recent data we've got is from 1920. So all of the data you can see here, and this one is the most recent data, is 21 at the latest. But actually this morning I've just gone and had a look at the child death data. So we have a child death overview panel, and it does look like the rate of infant mortality, so the infant deaths, is lower than 43. So that looks optimistic. It looks like we're about 29, but obviously it's not published data yet, so we really do need to wait for the Office of National Statistics to publish it so that we can compare like for like, but that gives you a general sense of where we're at. And I suppose what you'll want to know most is what are the modifiable factors. So at the top are the four kind of, well, top row and the bottom one of the second row are the modifiable factors. So every child who dies in Staffordshire is looked at by the Child Death Overview Panel. And when we look at those deaths, we look at what were the modifiable factors that were present. So the top modifiable factor is mothers who smoke at time of pregnancy and at time of birth. So the rate there for the number of mothers smoking is on the slide. It's in red because that means that we're worse than our statistical comparators. So that gives you an idea that actually that rate is too high and we really need to reduce that. One of the other reasons why we have a high rate of infant mortality is either very young mothers or older mothers, but the rates for that are kind of statistically about average, so that's not one of the reasons that we're looking at particularly. Another reason is related to breastfeeding, and again, we are worse than our comparators on breastfeeding rates. Another reason is low birth, we're about the same. Smoking at time of delivery we've touched on. But then one of the other kind of really significant factors is around whether or not mothers particularly access services and support throughout their pregnancy and beyond. So whether or not they speak to GPs, they access their midwifery appointments, whether or not they're in touch with their health visitors. So we've also included some information in there about the attendance at kind of health visiting key checks, just to give you an idea of what that looks like. Again, that data does lag, and I can tell you that the rate of new birth visits completed is higher than it is shown on that slide. So when I looked this morning at the 23-24 figures, we're at about 82% now, so it's gone up from about 75.6 to 82%. The other thing to just let you know about that figure as well is new birth visits have to be conducted within 14 days. So that's the thing that they measure, but actually we do also measure the number of people who take up that visit, and it is about 99%. So most people, 99% of people, will have accessed an appointment within the first 30 days of being back at home. So actually most people in the county are engaging with that services and support. So we wanted to include a bit of information about what we're doing as a partnership to try and impact on infant mortality rates. So we've been doing a lot of work around smoking in pregnancy. We've included some of the performance data in the paper that we circulated to you all beforehand. We know that this is the highest place that we can impact in terms of modifiable factors for parents. We have been commissioning a Stop Smoking in Pregnancy services for a number of years. We've just gone out to recommission that service. It's payment by results contract, and it does particularly well, and like I say, the data is included in the pack. We've made some changes to it this year because some of the parents fed back to us that actually they found it quite difficult to quit smoking when the targeting support was aimed at the mother because the dad was still smoking. So it has been extended to include household members this year, which we have found has had a bigger impact. But one of the biggest challenges we still face is that we're struggling to engage the right parents in the right referral. So rather than doing like everybody will be referred, you really need to be having a conversation about what does that referral entail to make sure that we get that kind of outcome at the end. So we have just taken a paper to the Maternity Transformation Board to get them to work with us to try and make sure that those referrals are improved for that service. The next thing we're doing as a partnership is we're embedding an approach called ICON. So one of the other modifiable factors when people return home is that often when you're lacking sleep as a new parent and you're getting stressed because you might have other stresses going on in the family home, quite often you can hear the baby crying, and sometimes people feel the need to shake the baby. And that is one of the modifiable factors that has come up at the Child Death Overview Panel. So we've been embedding an approach called ICON for over 2 years now, around infant crying is normal, and trying to encourage people to make sure that they don't shake the baby. And that's been a campaign that's been running across the partnership for some time now to try and encourage that. And as a result of that, we have actually seen the number of babies who are shaken reducing coming through this child death overview panel. The next modifiable factor we talked about then was around breastfeeding. So the rates of breastfeeding in Staffordshire are significantly lower than we'd like. Quite often I think people think, well, it's breastfeeding, it doesn't really matter, but actually it is a considerable factor when we look at the rates of infant mortality. As a result of that, we've had a breastfeeding coordinating group which has been running across Staffordshire and Stoke-on-Trent, and one of the first things they did was try to talk to parents about their experience of feeding. So we had a massive response to the survey. We had 752 responses, which we really weren't expecting. We wrote out to everybody who'd given birth since 2018 and asked about their experience. And all of the parents came back to say that actually the biggest thing that would have made a difference is that very early support. So actually when they've just given birth, within the first 10 days really, they wanted to see somebody and have that support because that was the trickiest time. They felt like actually there was a perception amongst the community where it wasn't very welcome to breastfeed in public, so they wanted us to raise awareness of breastfeeding and the benefits of breastfeeding, and also maybe think about the benefits from a parent's perspective. So particularly in the cost of living crisis, the cost of breastfeeding is nil, and so actually could be a real benefit that people could experience. And they asked us to make sure that the services and support were more joined up. So we've developed an infant feeding pathway, and at the moment we're trying to embed that across the partnership so that people know where to go to access the timely support. There are a number of different professionals that might support you in that kind of first couple of months really as you start to initiate breastfeeding and continue to breastfeed, whether it's through the GPs, midwives, health visitors, or a range of other people that might be in that community, so that pathway is broad enough so that actually people can see where to go to get that help if they need it. I suppose one of the things I would say, and I'm not sure this will come as a surprise to most people, is that the cohort of people that we're talking about, so we're talking about people who are smoking at birth, or we're talking about people who are not breastfeeding. Quite often we're talking about the same families, so one of the best things we can do is offer holistic support. So we can offer family-focused support at the right time, and one of the ways we do that in Staffordshire is through the health visiting service. So I've included some information on there on the mandated checks that are completed. As I said, most people, 99% of people get a new birth visit. Most people will take up their 6 to 8 week check. That's about 99% as well. So actually people are accessing that timely help and support. For the 1% who don't as well, we've just agreed with MPFT an information sharing agreement which will pass that information back to local authorities so that we can see if they're known to services. Which should again increase that take up for those most targeted people. And then one of the other things that we do as part of that service is we have a particular team called the Strengthening Families team. So the Strengthening Families team work with anyone, whether they are pregnant or have recently given birth, and they provide more targeted support for children that are known to services. So when we're talking about infant mortality, we're talking about a cohort of people who generally live in poorer communities, will have a less kind of affluence in the family home, will quite often be known to some of our services and support before. So this team works specifically with that cohort of people and will provide that integrated support throughout the pregnancy and into the first few days of birth. They'll often work alongside the early help teams or the social workers to provide some of that specific health support and intervention, particularly around some of those modifiable factors that we know exist. And then the last thing I thought I'd touch on is just the challenges or next steps for us really in relation to infant mortality. So there is a significant amount of work that's going on across the partnership in relation to infant mortality. I don't know if some of you might remember, but I came to talk to you about a partnership protocol a while ago. There are 16 partnerships that talk about infant mortality or have it as a priority. So in between now and the end of next week, I'm talking to yourselves, the Safeguarding Children's Board, and the ICS about infant mortality. And so actually, one of the things we've got everybody to sign up to is one whole system group, but actually understanding who is the right board to report into might be quite helpful. And I think that's one of the reasons why we wanted to kind of ask the question about whether or not the priority for this particular group needed to be broader than just infant mortality. So that's one of the conversations we wanted to have today. And I think that's it in terms of infant mortality. Like I said at the beginning, there was additional information included in the pack around the Children and Young People's Framework and also the co-production promise. And both Nikki and I are happy to take any questions people might have.
Thank you, Natasha. Before I move on and ask if anyone has any questions, Nicola, is there anything you wanted to add at all before we go to questions?
Natasha's covered that really comprehensively, thank you.
Okay, thank you very much. I've got a couple of questions myself, but I'll open it up to board members to start with. Gary, sorry, yes.
Thank you. Really informative, quite sobering. Just a couple of clarifications, if I can. Are the circumstances of the birth itself considered in the modifiable factors? So that was the first question. And I appreciate the numbers we're talking are quite small, thankfully, so this might be quite tricky, but is there any evidence that there's any inequalities linked to protected characteristics, particularly ethnicity?
I'll take the second one if that's okay, Gary. So there is a lot of evidence and research that certain cohorts of people are more likely to experience infant mortality than others. So particularly younger parents, older parents, or those from the black minority ethnic communities.
In relation to the first question, Gary, I'll take that away and pick it up with our LMS to clarify the data source and whether that's included or not.
Well, perhaps while others having a little think, a couple of questions. Well, in order, Natasha. Clearly, if we want to see what we're doing, if it works, or it has any impact, getting the data that's not 3 years old might be particularly beneficial. Because what we suppose we should be really doing here now is, if we're using data that's 3 years old, is talking about what we were doing 4 years ago. And so, if anybody can remember, so my point is why is the data? Is there such a lag? And is there a way of being able to get the data a little bit more up to date than what it is? Because I can understanding the cause of the death might take some while. There might be lots of circumstances that relate to that. But the fact that a child between certain ages has died, I would not have thought is difficult. I mean, these deaths have to be registered. Would have been particularly difficult data to have. I don't know whether you can answer that at all.
We had an initial chat yesterday, Mark, about this, and I did go away actually and have a look about why there is such a lag in the data, and I honestly couldn't find anything. Richard, I'm not sure if you know why the Office of National Statistics takes so long to publish it, but I couldn't find anything that was easy to find. The one thing I can tell you, though, is I did go away and get the child death overview data, because I thought, well, actually, that's a good indicator. They'd got recorded for the same year that the Office of National Statistics have got us as 48, they'd got recorded 46 deaths. And for the year after, they'd got us recorded as 37, and then going down to 36 and 36. So that makes me think if actually it's comparable, we have seen it coming down slightly.
Yeah, which obviously is an absolute positive, you know. But we're making a presumption, aren't we, that's right. So, if the overview panel have got the data, I just find it quite strange to understand why nationally it's not available. And I wondered whether there is another way we could get that data in any way. Richard?
So I would have thought it would be possible to establish a local system for collecting both the overall data, but also for a bit more of a deep dive into some of the underlying causes. So I appreciate the data is a bit out of date if you wait for the ONS, but this has been a fairly stubborn problem that's been intractable for a long period of time, and we have some hypotheses as to why that might be, but I don't think we have any really clear answers. And that the hypotheses fall broadly into two categories. One is things like the determinants of health. So there's things like genetic reasons for infant mortality, probably not an issue in Staffordshire. Behavioural reasons like maternal smoking, where it appears there is a problem. But the other group of factors is health service related factors. So are maternity services as good as they need to be? And I wonder whether it would be worth, if we're talking about 40 to 50 deaths per year, whether we can actually get the details of those and do a deep dive to understand infant by infant what it was went wrong, and just understand the data in a bit more detail, because I think that might give us more insights into what sort of interventions are likely to be most effective.
Thank you for that, Richard. Natasha, just following up on that. So the overview panel, then, how much of that does that already do, or does it just select certain child deaths?
So there is a child death overview panel. That child death overview panel runs across Staffordshire and Stoke-on-Trent, and it does just that. So it meets and it discusses the deaths of every single child in Staffordshire. So I've got in front of me a list of the 38 children who died 3 years ago. So we can see factors, and that's what we do. So when we say smoking in pregnancy is the most common factor, that's based on the information that we pertain from those deaths that happen. So when it comes to was it 28, I think I said on the first slide, that happened in the hospital, that wasn't necessarily the most common modifiable factor, but once they get out it might have been, and we do look at each of those children in detail, which is what informs the work that we then do. In Stoke, we've been working as a system, and this is what we're going to talk to the integrated care system about next week. We've been working on, they've done a deep dive where they've done some work around looking at what were some of the things that happened in terms of access to healthcare and support, and they've come up with a priority around just that, Richard, so one around access to healthcare and support. So we're going to take the learning from that next week and use that to inform the plan that comes next. But so far what we're seeing is the access to health services in Staffordshire is not as significant as an issue as it is for Stoke.
Yeah, thank you for that. I just wanted to add a couple of points to that. One was that the rate of mortality is higher amongst Black and Asian communities, and that's across nationally, and it's something that gets brought up in the Health Watch England networks. So that's something I can see if I can find some more data on nationally and bring that back here at a later date if that's helpful. The other part was that we are looking at doing some entrant views, especially we're looking at doing it at Royal Stoke Hospital maternity ward, and we can expand that, and again we can bring those findings back here again if that's helpful.
Just an observation really, as we go through the reports that we're getting on the priorities that the board has identified, unsurprisingly, I think we're beginning to find that the cohorts that exhibit the health problems that we're looking at are very similar, be they defined by geography or wealth or whatever. And I think there's an exercise, perhaps linked with the JSNA, at the end of this to look at the interventions that health and local authority and other services are doing, and just making sure that we're coordinating the interventions and the messages and so forth, because I can see a disadvantaged family being bombarded with all sorts of advice and interventions, and if we're going to make any of that effective, we probably just need to understand it a little bit from their point of view, and try and coordinate some of that better perhaps, but not an easy thing to do.
Well, thank you very much for a detailed report, Natasha. As you know, I'm quite anxious that we don't lose the focus on infant mortality within that bigger picture, but I do recognise the bigger picture is important. One of the questions I wanted to ask is that you identify the prevalence of smoking in pregnancy as one of the key factors, whether actually alcohol and drug use is an emerging factor, or whether in this part of the world it's not of any great significance. And I think Tim makes a very good point. We do all these services. I think at some stage one needs to take a bit of a critical appraisal and say which ones work, which ones look as though they're working, and equally which ones don't, because not everything works. And I think there's no shame at all in saying, well, actually, we've been doing this, but it's not delivering the results. As Richard has said, it's been a bit of a long-standing bugbear, this has. And one would perhaps think that perhaps not all the interventions are as successful as we would wish them to be, and perhaps there's a time to rationalise and refocus on something else. So I do think that that's a very helpful comment that Tim has made, but I just wondered whether drug and alcohol use has now or is an emerging issue.
So, Julie, when we've looked at the data, it's not currently something that's coming up as one of the top things we should be looking at. That's not to say it doesn't happen in some instances. When I listened to you talk, Tim, I did actually think we have missed a trick here, and maybe this is one for us to take away, because as part of the Supporting Families programme, we do use a range of data indicator sets to try and identify people and make sure that we coordinate the support around them, as you know. And as part of that, we do also look at the outcomes that are achieved for families. And I don't actually think that this data set is in there as one of the, you know, so smoking and pregnancy, for example, I don't think is in there as a data set that we collect and include as part of that. So we'll take that away and go and have a look. And if not, try and see if we can get it included.
Yeah, it's just to say that alcohol, it does remain an issue, but it remains an issue in terms of the development of children and young people. So there is a particular sort of fetal alcohol spectrum disorder that obviously we are seeing a higher prevalence in, particularly in children and young people, but also adults who've gone undiagnosed as a result of that. So there is, again, a partnership group that's in place between the ICB and our local authority partners to look at that in terms of the wider impact. But in terms of the interventions around, we're obviously governed very much by the Saving Babies Lives bundle, and obviously there's a new sort of peri-prem bundle that obviously the maternity partnership is looking at in terms of the specific evidence-based interventions, as you say, that are the ones that we know work and will make a difference. But we can certainly get some more information on that and get that to you.
So my point was going to be around the numbers and really looking at, in the cohort, I wasn't clear whether there were any repeat families coming through, because each time we are dealing with a different family. And what we've heard is there's multitude of factors that are playing a part. So you picked up the 3 or 4 common ones, but they may be present. In some families, there might be only 2 factors present. In others, there might be all of them present. So really, numbers are small enough for that sort of deep dive. Other thing is, if our numbers have gone down to around 36, in totality from any child death is a tragedy. But in statistical terms, is the reduction significant? And are there common things we are doing? And then I also just wanted to pick up more at a qualitative level about experiences of Black and ethnic minority group women. Because some of you might remember a couple of months ago, there was quite a national reporting of it and publicity. And when you heard individuals talking about their experiences, it was often they weren't heard, they weren't listened to, or they were told, oh, well, you know, you have higher pain threshold. And that sort of thing is not necessarily going to appear in your individual factors that we are looking at. So how are we at that cultural level setting that leadership tone, expectation? How are those issues also being addressed as part of this agenda? So that those were the sort of thoughts I had.
Yeah, really interesting data, thank you. I suppose the question I would like to ask is, some of the factors that you've identified are a direct cause of the harm. Some of them will just be how we identify the families who are likely to have harm. So something for me, because clearly smoking in pregnancy has a direct effect on the infant and would lead to that higher probability. But there's some that would just say, well, actually, they might have had an RTA and happen to be from a smoking family. So there's something about extracting what are the causes of death in those 30-odd children, versus and I guess that would then help in terms of the level of impact that would have.
Do you want to come back at all, Natasha?
So, Rachel, in terms of the data around whether or not there was an issue present in the family home or whatever, we have that information, so we can circulate that to you if you want us to. In terms of, Neelam, your question, the group of people in terms of black minority and ethnic communities are disproportionately represented. It's 8 of the 38, which is nearly 25%, which you think about the general population is not necessarily in keeping with Staffordshire. So I think there is definitely something we need to do better around the services and support for those families. In terms of what is the system's response to that, I think we'd have to go and take that away and have a look at it and ask the system actually what are we doing now that we have identified that as an issue that we need to look at. But we can certainly come back on that in terms of the plan.
Thank you, Chair. I was going to say, in terms of the system, for me, and this is partly why the co-production promise is in this pack, because it does relate, and there are commitments in there that the children and family support system are making to listen to people, not just now and again, but every time. And so for me, that's why the co-production promise is critical, because it sets the tone, not just for the partners, but also for the recipients of support, because they can use that promise to challenge the service level that they're getting and the support that they're getting. They can use it as a tool to say, this is the promise from the Staffordshire Partnership to do this. So for me, that's how this fits in. Obviously, the key is the launch and the embedding of it rather than the creation of a document. So that's going to be the challenge for the partnership over the next, well, for the foreseeable future.
Before we just finish on this, there's the point that you raised, Natasha, which I don't think we've particularly looked at, and that was the sort of governance of this and where it best lies. And you talk about 16 different boards or panels having this as a priority or looking at it. And although there's nothing particularly wrong with that, because each of those might be looking at a particularly different aspect, what I would certainly think is important, and welcome to listen to other people's comments, is that they all get the same information to be able to decide what the priorities are, and there is some coordination so that you haven't got 2 different panels, 2 different boards doing exactly the same thing, perhaps sending away and getting the same officer somewhere in the system, be it in health or be it ourselves, doing the same piece of work. So I think it would be useful to try and see if we could join that up a little bit, and may well save yourself, your staff, and other people's staff time from having to go and report to so many different boards and organisations, because it may well be some of those it's just on a list of things that's important to them, and I don't know, other than the ones you mentioned, which boards or panels you're talking about, who don't really actually give it an awful lot of thought. So I think there's certainly some work to do there, and I think we've highlighted that perhaps we need to use some of that information from CDOP, exactly some of the causes, and something else that, and I know it's difficult when you reduce the amount of numbers, and you did about across the district to see whether there's anything in the what's different from one district to another, or are they particular parts of a district that are serviced by a particular team, and there could be lots of things. And I think if we're going to have a real impact on this, that along with having up-to-date data, so we've got some ideas, and we could be sitting here, couldn't we, and saying actually what's been put in place over the last 3 years, he seems to be working, and we just need to continue in that trajectory. So does anyone have any other comments before I just go through the recommendations at all? Okay. So the recommendations to the board are that we note the progress being made by all the partners in Staffordshire regarding healthy start in life. We support the widening of the focus of children and young people beyond infant mortality to encompass the work we are doing on the wider detriments of health to improve outcomes for children and young people. Endorse the CYP framework, which has been developed by the programme board, delivering on behalf of the ICS. Endorse the co-production promise as a critical way in which we plan to work with CYP and F, and considerations of all in consideration of its use across the broader partnership, and E, acknowledge the planned work across the partnership and continue to support the development of these programmes of work over the coming years. And I would add to that another one about the things I've just raised about that work, particularly on infant mortality around CDOP, so we can understand a little bit better, and also to try and get into a position where we've got that data earlier. So don't we make a note of those, Liam? And
Yeah.
is that fine? So everyone happy with those A to E and the additional F that I've added in? Yeah. Excellent. Thank you very much. Thank you for that. Tasha, thank you very much for that. So, item 3 on the agenda then is Health Watch Staffordshire progress and update on 3 deep dives. And that's over to yourself, Bas. Thank you very much.
Thank you, Chair. I have submitted a report. I'll take that as read. I will use these slides to pick up the key highlights and take any questions at the end, if that's okay. So today I'll be giving an update on our 3 deep dives. These are root causes of good and poor teenage mental well-being and health outcomes when you've been in care as a child, access to primary care and seldom heard groups. We have been working with Health Watch England to use a theory of change model to help us to focus our resources in the areas of this deep dive where it's most needed, increase the chance of successful outcomes, identify what is working and what is not, so we can adjust our approach and target resources, measure and communicate the effectiveness of our work, and evidence the outcomes we achieve. As part of our methodology, we have been working with our partners to co-produce recommendations. We have been working, seeing people face-to-face, patients and residents, such as in pride events, the PPG groups or carers groups. We have been working with focus groups, carrying out surveys and questionnaires. So with our first deep dive, root causes of good and poor teenage mental well-being and health outcomes when you've been in care as a child, Health Watch has been working with Staffordshire County Council and the ICS to help coordinate and contribute to the development of a new Staffordshire joint mental health strategy to address and help to improve the mental health and mental well-being of young people. The joint strategy aims to use these 6 key outcomes that have come about. They have been identified through engagement activities. So what we know so far, having worked with young people and our partners, is that some of the root causes, I would like to just reiterate, in the final deep dive report, there will be more added to this. So there's not an exhaustive list here. So there are family dysfunction, concerns around family dysfunction, experience of discrimination or stigma, having long-term health conditions or sensory disability, severe or long-term stress, social isolation, loneliness or bereavement, social disadvantage such as poverty or debt, instability in family placements. There is also concerns around those involved in criminal justice, the youth offending services, and substance misuse. From speaking to the young people, some of the highlights around their mental health concerns are anxiety, depression, post-traumatic stress disorder, low self-esteem, isolation, and suicidal ideations. What we do know is about the service provision available, so it's leaving care services from local authority. We've got mental health services, so this includes the children and young people's mental health services, and that those transitions into the adult mental health services. We've got accommodation support services. We've got the education, employment and training support services. We've got substance misuse services such as ADSIS and STARS. And then there is a single point of access for children and family. And we are also promoting this to help get that further out to, so anybody can make that referral, whether you're a GP or a carer or a family member. Some of the early key themes and recommendations are that primarily young people would still prefer to have face-to-face appointments as opposed to digital Now that's quite different from more a physical ailment when it comes to a general, like a GP. Then they'd prefer to have more digital. On this, when it comes to the mental health, they do reiterate that face-to-face is their primary choice, but with the flexibility of digital over the phone. Some of the other things we are highlighting from young people is that the transitions from the children's mental health services and into adult mental health services needs to be smoother and to reduce the risk of vulnerable people slipping through the net. Some of the other suggestions are around the waiting times when young people are referred into mental health services. And it's looking at mind, actually for young people, yes, starfish, stars and changes. As Health Watch, we have been working with the ICS Children and Young People's Mental Health Systems Improvement Board, which brings together the ICS partners from across Staffordshire and Stoke-on-Trent to identify and deliver improvements to mental health systems for children and young people. Our early findings and recommendations for this deep dive will be fed directly into this board to inform their activities. This board has several working groups focusing on specific areas of work. I'm just going to mention two here. The Care Experienced Children and Young People Mental Health Working Group. So with this group has started to identify the gaps and barriers in relation to the mental health offer of care experienced children and young people, and the Health Watch findings will enhance this. Once we understand the gaps and barriers, we will start to address them as a partnership. The second working group is a prevention working group. One of the areas of focus for this working group is targeted prevention. So targeting prevention activity on those groups who are likely to be more at risk of poor mental health outcomes, one of these being care experienced children and young people. Health Watch Deep Dive will be used to directly inform this work, particularly our findings around the journey of these children and young people through services and the risk factors that could be identified earlier in the journey to further support making sure that vulnerable people do not slip through the net. The feedback from our findings will support the prevention group to identify those potentially vulnerable cohorts and help this working group to ensure that their prevention offer is accessible to young people, prevents their needs from escalating. We do intend to work closely in partnership to ensure that the Good Mental Health Strategy Action Plan and the Children and Young People's Mental Health Local Transformation Plan complement each other. Some of the actions within the Good Mental Health Strategy Action Plan will be delivered by the ICS Children and Young People's Mental Health Board and the working groups that sit underneath it. For our second deep dive is into access to primary care. What we do know is that 92% of all NHS consultation takes place at the GP, and this is generally where, as a Health Watch, we do receive the most amount of feedback from members of the public alongside dentistry. We have been, throughout this deep dive, we will be referring to the fuller report, which is what has been used by the NHS England to set out the roadmap for primary care improvement. The issues are around access itself as opposed to the treatment. The treatment generally, once people get into treatment, they generally see that as positive and feedback is positive. It is the points of access. And just two pieces of feedback to illustrate that. I made 210 calls over 2 days before I got through, but once I did, I was booked in and got the treatment I needed. There's another person, I rang my GP surgery, booked my place in the queue and waited 2.5 hours for a call back, and then I was told there was no appointments available. And that just reiterates the kind of experiences that patients are having. Some of the engagement strands are that Health Watch has been working with PPGs, carers groups, the ICB primary care managers, the 111 district nurses, pharmacies, GPs, Health Watch England, and social prescribers. What we do know is that under the new primary care recovery plan, GP surgeries are required to tackle the 8 a.m. rush and reduce the number of people struggling to contact their practice. Patients should no longer be asked to call back another day to book an appointment. There is in the plan that they should be receiving a scheduled appointment, if it's non-urgent, within 2 weeks. Health Watch has been supporting the ICS with their primary care access campaign in line with the new delivery plan for recovering access to primary care by promoting the additional roles reimbursement scheme so in short Rs. Healthwatch has been influencing this campaign with valuable patient feedback. So as you can see, some of that patient feedback that will be used on posters and leaflets, back of buses and various notice boards to get that information out. The idea is that they're trying to improve access to primary care, and it's an attempt, and it's a good attempt to bring the public along on that, which is, again, where that's been highlighted as an issue. We have been supporting this, and we will be taking these out as well to further promote those. We also supported with a series of materials such as these videos that have also been released. These 5 videos showing 5 different R's roles and how they can help patients. These videos outline why it may be more beneficial for a patient to see, for example, a physiotherapist in the first instance as opposed to a GP. So as opposed to going to a GP just to be referred back in, they can bypass that process and go directly. Also with these R's roles, they do get longer periods of time to actually have a good consultation, to really talk through what's going on. So some of the early key themes from patient feedback and some of the next steps. Neurodiversity is coming up, something that, so from patients, they're saying that reasonable adjustments need to be required for patients, especially around communication needs. I will highlight, and I've added this in the appendix, is about the health passport, where those people with neurodiversity can have help to have this put down on their health passport, and then they can present that, so it informs professionals on how to support them better. Cost of living, again, people are struggling out there to pay for prescriptions and around travel for appointments. Telephone access, again, remains an issue. Patient registration, especially with new estates going up. Sometimes people want to register with a GP that's quite close to them, but when they go to allocations process, they can be told to go further afield. The challenges of adopting the digital communication. We do feel that some people find this empowering and other people feel this quite difficult, because with digital communication, you can see your own medical information, which is helpful for quite a lot of people. But those that feel digitally excluded, this is where some of those R's roles could be a bit, work really well to help support people to better understand that, to be more empowered. There have been mixed experiences and feedback with the NHS 111, and this has been now fed back to the ICB urgent and emergency portfolio to support the improvement of that. An example of that being somebody contacted 111, was told to go to A&E, to wait there for 2 hours, to be told that wasn't the appropriate place for them, and that used up a day and they still didn't have their needs met. Some of the next steps, we're looking at the potential role of PPGs, how they can support the changes to the local practices, helping with patient communication and promoting health and well-being, as well as the R's roles, to continue working with the ICB primary care managers to understand the county-wide implementation of the primary care improvement plan and how they can promote this to the public, and again, reference to the R's roles, to develop a simple guide, and we will do this with partners for patients, which sits alongside the changes to assist them in securing the best out of primary care. Some of the challenges around that is lots of GP practices are different sizes with different demographics and in different areas, so creating a simple guide will have some challenges, but that's why we will work with partners to ensure we get the best out of that. We will look at events to share this information and findings, and we'll consider looking at patient feedback early in 2024 on the effects and the changes on patient experience here, possibly looking at the GP National Survey again as well. For our third seldom heard, this deep dive focused on 3 areas, which is the transgender community, which is within the LGBTQA+ community, people with neurodiversity, with neurodiverse conditions, and those in rural areas, so rurality. We did have an early start with working with the LGBT community. This allowed us to create a really good report that we were able to pass over to various partners within the VCSC sector and the ICS, as well as Healthwatch England and other local health watches. And this also went over to Manchester Pride. We found this really helpful when it comes to giving information advice, well, good information advice and guidance at other Pride events that engagement officers are attending. Some of the issues that people from the transgender community have been facing is long waiting times. What we have come across is that when somebody is paying for it privately, they will get the treatment done a lot quicker, but that does highlight health inequalities when it comes to those that can afford treatment, those that can't. And we're just mindful of that. So with neurodiversity, what we found is that neurodiversity here refers to the diversity of all people, but is often used in the context of autism spectrum disorder, so ASD, as well as other neurological or developmental conditions such as ADHD or learning disabilities. When we were formulating the surveys, when we were carrying these out, and we spoke to staff that work with people with neurodiversity or patients, they did say they preferred to have their condition referred to as co-occurring. So we kind of added that in there for now, but not taken out necessarily neurodiversity. We promoted this across our networks, especially our Health Watch Intelligence Network, and carried out surveys and worked with our partners. This has increased from 65 responses now to over 80 responses. But generally, and we are still in the process where we're beginning to now look at the data, so it's quite early stages to really understand what this data is saying to us. But as a quick early indicator, 80% of the respondents are carers. Of these 80% of respondents were telling us about ASD spectrum, and their feedback was that the condition affected them a lot when visiting a GP, a hospital or a dentist. The patient feedback highlighted they wanted professionals to have more understanding of co-occurring needs, as they feel that this would allow more improvement around access to services. So people would take more time with them to understand that it takes a little bit more time to understand what their problems are, rather than closing them down early. The final report will also include examples of policies that are already in existence, plus good practice, such as the health passport. And for the third one, it's about rurality. Now, this is again increased. We've got over 50 completed surveys. Again, mostly from 50-year-old people or older, and those from white British backgrounds. Most of the respondents said they travel under 11 miles to visit a GP, optician, pharmacist, or a health centre. The majority said they travelled more than 11 miles to visit a hospital. Around 30% of respondents travelled over 11 miles to visit a dentist. A lot of the concerns they raised was about the costs that it takes for them to travel and the time it will take for them as well. They would prefer to have services closer to home. In addition, the service highlighted feedback around the lack of public transport was an issue to get to appointments. An example of that is people in Biddulph don't necessarily class themselves as in a rural area. However, when they feel there's a lack of public transport, they kind of present with similar feedback around how they're feeling. Some of the early recommendations is to use the health centres more for additional services, so more ease of access as they're under 11 miles. To work with partners and highlight the need to improve public transport to make it easier to access services further away from their homes. Okay, thank you.
Baz, thank you very much for that. Any questions on the Health Watch report at all from anybody? Julia?
Very interesting report. Thank you very much, Baz. Can I just ask, because there's a lot of information here, but it's understanding what it means, and particularly with the work that you've done with young people and mental health, saying that, their anxiety, they've got depression. Is that self-diagnosis? Because I think as a society we're misunderstanding that part of growing up, you get anxious and a bit down in the dumps, or you can be quite down in the dumps. But there's a degree of that's normal. So I just wondered whether that feedback was from a professional diagnosis or a self-diagnosis, because I think we need to understand the context of it.
Yeah, thank you for that. That's a good question. The feedback we're getting so far is that one of the engagement officers is engaging with specific groups of young people in care settings. And yes, with care settings, sometimes there will be genuine diagnosis that those young people are describing from. Other times, they will be just discussing it amongst themselves and probably say, oh yeah, I feel like that, therefore I've got anxiety, or I feel like that, therefore I must have. And that will be something that we could probably look at, maybe knuckling down a little bit more, just to understand if it is more diagnosed-based, or if it is that they're talking to each other and kind of picking up some of those, you know, those similar symptoms and reflecting it back to us. Because effectively, in practical sense, it's going out to a group, speaking to them, and that's what they tell you back. How do you feel being somebody in care? But again, it's something that we could, as the groups are still ongoing, we can pick that up and ask that a little bit more in depth.
It's just to follow up on that in terms of the sort of latest data suggests that there's about, you know, every 12 in 100 children and young people will have a diagnosable mental health condition, but that doesn't mean it leads to a diagnosis necessarily. So that's why in terms of the NHS we have specific targets around children and young people's accessing mental health services, and that can be some of the services that you mentioned, like Action for Children, that we commission jointly with Natasha's team in the local authority, and obviously our NHS services as well. So there's a big sort of programme around that, recognising obviously there is an increasing need around children's emotional well-being and mental health issues, definitely.
Yeah, thank you very much for the report. Thought really interesting. Just a couple of small points from it. One is you talk about the ability for people to communicate digitally, and you also talked about somebody spending time doing 210 phone calls to try to get an appointment. And certainly in my GP practice now, they've introduced a digital triage system where you can go online and briefly describe what your issue is and what you'd like help with. It's a bit clunky, but if you haven't got time to do 210 phone calls, which most of us around the table haven't got to do, it's quite helpful. But it would just be really interesting to, I think, map best practice in that regard, and how it might develop to be more inclusive to those people who find it difficult. And I wondered if there was plans to do some follow-up on that. My other question was, I was really interested in the work that you've done around neurodiversity and the questionnaires to people with regards to that. And again, wondering whether you were going to do some follow-up work, because I absolutely can see that if health and other professionals have got some understanding of neurodiversity, that's really helpful when you get face-to-face. But for some neurodiverse conditions, I imagine going to a big, I went to UH&M the other day, to go into a large hospital, there's very real danger of sensory overload and all sorts of things in terms of just being able to present for that appointment. And I wonder whether there's a longer term piece of work around just thinking about how we make that process easier for people so that they can access care. Thank you.
I just wanted to pick up on your first one around digital and access. It's one, it is, I think for some people, is just a new area. They're not used to it. The other part is that depending on where you are across Staffordshire, especially some of the farmers we've spoken to, or the people within the farming community, they don't tend to have internet access or get phone reception on a regular basis. So I think there's some of those barriers that will come into it for some people. What we do know is that those people that are supported to use digital do tend to like it. I think that's where this is going to be a bit of work here, that if, especially as mentioned with the PPG group, kind of disseminate that information back and showing the positives of digital. So it's kind of moving that cultural move forward. I know, speaking to one or two other health watches in different areas across the country, some GP practice have moved over totally to digital, so there is no initial phone call, but they found that it was really good because they got like an interactive service with that GP, and they were informed on a regular basis about what's going on, so they didn't feel in the dark. So actually they were really promoting that and said that really worked well. So again, kind of answering your question there is how we're going to bring everybody along on that journey, and it's working with partners so we're all saying the same thing and training people, members of the public, to use that better.
Yes, please. It was just to pick up to follow on from Tim's point as well. So there is a really, I don't know if people have heard the training around Oliver McGowan, but it is a really, it's a nationally mandated programme now around training for the whole of the NHS and social care workforce in terms of understanding the impact around for people with learning disability and or autism in terms of health services. So under the Learning Disability and Autism Partnership that Karen Webb is currently leading on behalf of the ICB and also Staffordshire County Council, works for Staffordshire County Council. We've got a big programme in place to start. So we're just in the initial stages of scoping that. So we have a project manager in place, but there's going to be a sort of 3-year programme around making sure that we, all of our workforce that's CQC registered in some way has to go through that training, precisely because of the huge impact that not getting it right for some of these individuals with neurodiversity has. And I would encourage anybody to sort of have a look at the Oliver McGowan package and just have a look at it, because it really does resonate and bring it home why it's so important to make sure that our workforce is appropriately trained and makes those adjustments for that really important group of people. Thank you.
Gary, perhaps if we can make this the last point, just so I can keep on time.
I should probably just preface this with Health Watch Staffordshire sits under Support Staffordshire, so there's a sort of declaration of interest, I guess, there. And I guess it's to that extent, I just wanted to just remind that Health Watch's role is to shine a light on things that are most important to public and the patients. That isn't always the same thing as the things that are most important to the service providers. And also it's a reminder that the service Health Watch as a service has to draw a line under things and then move on to other things. So it's not for Health Watch to necessarily follow all of these actions right through to completion and implementation. And it's kind of to say, this is what the public think is really important, and over to you guys as the providers almost. So that was sort of point one. The second one is that this was the first year under the new arrangements, and we took a decision to have this deep dive approach to look in much more depth. I'm really pleased with the outcome for that year one, but I think some of our learning in that has been that whilst we've tried to be really collaborative about it, I think it has slightly suffered from too many cooks. So Baz presented their 3 deep dives. In actual fact, it's about 6 or 7 in there, and that was because there was too many people saying we think that one should be the priority and we think that one should be the priority. So I'm going to be, from a distance, but pushing the team to be even more focused when they do another round of these next year, to narrow it in and focus it in even more so that we can go really deep, but it will mean the breadth. We won't be able to do as many things, or the team won't be able to do as many things.
Gary, thank you very much for that. I think a timely reminder for the board that I think part of this board's role is, to listen to what the public see as an issue out there, and take that into account. Certainly, from my own perspective as an elected member, talking to people, access to GP services, primary care is something that regularly raises up to an important point. So the recommendations for the board are to consider and comment on the progress made by Health Watch Staffordshire on those 3 deep dive areas. I think we've happily listened and we've made some comment. So I think in that case then, thank you very much, Baz, and thank you, Gary, as well for that. We'll move on to the next item, which is item 4, and that's the CQC Single Assessment Framework. And welcome, Amanda.
Thank you, Chair, and thank you for inviting me to talk today about local authority assurance framework. I'm here today because one of the stakeholders of the CQC regulation will be the Health and Wellbeing Board. So I'd like to just talk you quickly through the presentation slides that have been sent through with the pack. highlighting the areas that are probably more likely to be relevant to the Health and Wellbeing Board and what CQC may or may not ask you. So a quick reminder in terms of the local authority assurance. We're part of the new Care Quality Commission regulated arrangements. So as you know, CQC already regulate providers, including adult social care providers, NHS providers, and in future they will also regulate integrated care systems and local authorities. So it's those two sections that are new, and I'm going to be focusing on the local authorities part of it. But it's the overarching framework where we'll have safe, effective, caring, responsive and well-led as the key questions for all areas. So how will local authority assurance work? Big caveat at this point is that it's all very pilot-based at the moment. We haven't got the official framework, we've only got a draft framework. So everything I'm going to say is what the draft framework is currently saying. So we understand an assessment of a local authority will take about 20 weeks. So we will receive a letter saying that Staffordshire has been selected. And then we will have notice to collect evidence to submit to CQC. And they will primarily review that off-site. And they will then come in on site for after a couple of months to visit people, talk to people, partners, our staff and our leaders in meetings. And that will produce a report of which we will get a rating of outstanding, good, requires improvement or inadequate. In terms of how they're going to assess us, we've got 9 quality statements across the 4 themes. In a moment, I'll go through each of those, and if I go through them quickly, and then if you've got any questions on particular areas, please feel free to ask. But fundamentally, they are here to assess, is the local authority meeting the Care Act regulations? So that is the scope of their work, unlike regulations for NHS organisations, which are a bit more wider, is very specific to the Care Act legislation. In terms of how they're going to score us, for each of those quality statements, we get scored on each of these areas, and what they're saying at the moment is that they're all going to be weighted equally. So the voice of the person gets 20% of the score, if you like. So they will be speaking to people, asking for their experience of care, unpaid carers, and also taking feedback that we receive in the council from feedback we receive, complaints, compliments. And also want to case track 6 people's journeys. So from when the council first knew that person to where they are today, particularly focusing on the last 12 months of their journey. So very much taking that person's view in terms of their experience with the Care Act. We'll speak to staff and leaders, overview scrutiny, and we also have to submit a self-assessment of our views. They wish to speak to partners and gain their views, of which Health and Wellbeing Board is one of those partners that they've listed, voluntary sector partners, NHS partners, etc. In terms of processes, they've asked for a key number of documents that we'll have to submit. They're currently testing those out with the 5 councils who are being piloted. But one example, for example, is a copy of our JSNA, which I know the Health and Wellbeing Board see, so they will request a copy of that. And also, we will get scored on a number of key performance indicators, of which there are not many, actually. So the focus is very much on the views of people and the views of partners and staff. So, quick review of our self-assessment to date. So we've spent some time speaking to us as staff, and I'm going around speaking to partners as well to get views in terms of where we are against these 9 quality statements. At the top of the slide, you'll see there's some we statements and some I statements. That's what CQC have currently provided. We don't have a very detailed framework or key lines of inquiry. Those are the statements that we're going to be tested against. So for the first one, we maximise the effectiveness of people's care and treatment by assessing and reviewing their health care, wellbeing and communication needs with them. They will be seeking evidence that we are achieving that statement. In addition, focusing on the people's voice, they will be, when they speak to people, they will be expecting that people say something similar to, I have care and support that is coordinated and everyone works well together with me. So they were the kind of evidence that we've got to assess against. So in this particular area, this is about our Care Act assessments, and that we review those Care Act assessments every 12 months, of which, as you can see on the screen, we've got very good performance in terms of timescales, but also our quality audits, which assess those assessments, are also positive and demonstrate they're strength-based. We also want to do more, so we're implementing online assessments and continuing our work on strength-based practice, as well as recognising that we currently have delays in financial assessments, so we're putting additional resource and reviewing our processes to improve that. Supporting people to live healthier lives is the second quality statement, and this is the one where I think there's particularly quite a lot of overlap with the health and wellbeing strategy. By definition, this is about how we prevent, reduce, delay, and enable people to be as independent as possible, which clearly aligns with our health and wellbeing strategy. In this area, we talk about information, advice and guidance. So CQC will be seeking assurance that people find it easy to access information, that's accessible, and that supports them to live independently. And particularly, for example, our supportive communities arrangement and how we signpost people to areas in their local community to enable them to remain independent. We are aware that in the latest survey, it demonstrated that 64% of people find it easy to access information, advice and guidance. So CQC may ask us, what about the other 36%, of which we recognise, and we're doing work to develop our website and test it with people to see actually does it provide the information, and also assessing the information that we provide in other formats to make sure it's accessible and it is understood by people. We also recognise that we've currently got waiting times in occupational therapy, which is really important to enable people to remain at home in terms of accessing equipment. So again, we put additional resource into that area, are reviewing our arrangements in there as well. Equity and experience and outcomes, it was one of the last quality statements that CQC added in. Previously, equity was filtered through all of the quality statements, but they've now put one specifically in around this area. And it's focusing on protected characteristics, but also particularly looking for those people who are likely to experience inequality in experience and outcomes. So do we know who those people are, and how are we supporting them to access our services? We feel we're quite strong in this area in terms of our strength-based approach, as encourages all our practitioners to focus on the individual who's in front of them and look at their needs, whether they be religious, cultural, etc. So our strength-based approach takes all that into consideration. But we also want to do more than that in terms of assuring ourselves, speaking to community groups to understand, are there any barriers to preventing people accessing our services that we don't know about? So it's the unknown, so providing that assurance in terms of that. Care provision, integration and continuity is about the quality of care and ensuring that the care that we provide and is provided and we commission is of high quality and is sufficient to meet the future demand we have today. And again, we're very proud of the amount of quality of care that is rated as outstanding and good, and how we compare nationally and regionally. And also we're very proud of our timescales for brokering care once a need is identified. We recognise that we want to do more in terms of improving access for direct payments. Similarly to the national trend, the use of direct payments has reduced over time. So we want to do we're doing some work with people and our practitioners to understand why that is and address it. Partnerships and communities. This one is all about how we work together and keeping the person at the centre of that coordination. And in this particular area, we're very proud of partnership working with our voluntary sector and supportive communities, linked back to the one in terms of remaining people to remain independent, sorry. But areas we need to work on, as I mentioned right at the start, we're aware that the ICB will start to be assessed under these new arrangements as well. So we want to work closely together as we both learn about the new arrangements to ensure they're assigned, and continue our partnership arrangements with the district and borough councils regarding housing, which is clearly a key determinant in terms of accessing adult social care. Safe systems, pathways and transitions is all about people moving between settings, so particularly from hospital to home, from different community care settings, from children's to adults, to provide that assurance that that person's journey, that safety, and it's coordinated and the person's kept at the centre. We're very proud in Staffordshire of our discharge to assess pathways and how we work in partnership with the NHS to have those really accessible discharge to assess. And in this one I pick out our preparing for adult pathways. We're doing a lot of work with our children's colleagues to ensure in every scenario that we're doing that transition safely. Safeguarding is about the Care Act and Section 42 inquiries, ensuring that we are keeping people at the centre and making safeguarding personal and how we address that risk. Again, we're very proud of our timely triaging and safeguarding contacts. Where we do have increases of demand, we are aware of them and we very quickly put additional capacity in to address that and how we move to ensure that safety is our priority. What we do want to do in this area is ensure feedback to inform future planning. So when someone has a safeguarding incident, how do we learn from that? So in terms of their experience, and how do we get that feedback to inform future safeguarding arrangements? So again, that voice of the person is really important to us in terms of designing our practice for the future. And then the last two are around the well-led category, as it was in the NHS framework. So governance, management and sustainability. Do we have a clear plan? Do we make decisions? And do we recognise risk and how what roles and responsibilities are clearly defined? Again, we're very proud of the robust governance, performance management, and in addition to this, we've asked our overview and scrutiny to provide the challenge of our self-assessment to really assess that we've really been consistent. And in the areas to work on, we're very proud of our co-production arrangements. We've got some really good examples, but providing that oversight in terms of having a consistent co-production policy. And finally, learning improvement and innovation. So CQC, I'm sure, would expect every council to be perfect, but in that may not happen in every single circumstance. But what they do expect is when things go wrong, that we learn from those incidents and complaints. So we have arrangements in place to ensure that we learn from complaints, but we want to do more in terms of that consistent collection of people's feedback to ensure we keep that journey. So we've implemented things like when we complete an assessment, it now sends off automatic feedback requests so that we get getting that honest feedback. And also continuing to embed that two-way staff feedback. So seeking that assurance that our staff feel able to raise concerns and that we're feeding back to staff in terms of what we've done about them. And also those good practice as well. So that's one of the benefits of these new arrangements has been the really powerful, positive stories that I've gone around when I've spoken to staff and given me examples of how we're working with people. And that's really, really important too.
Amanda, thank you very much for that. Time to take any questions. There's no particular recommendations from this. It's just the presentation. So I'm sure Amanda will happily answer any questions, points you've got to raise.
There's been some quite high-profile coverage of the way that ratings are used for schools in recent months. Are we led to understand that there's going to be that similar one-word sweeping pen assessment of this, which just seems to fly in the face of that recent learning from inspection of schools?
The CQC have indicated that we will get an overall rating, so the outstanding, good, inadequate, etc. But we will also receive a report that identifies how they've got to that position and what learning we may need to take on board.
But we know the report won't land in the papers. It will be the one word, which will be, yeah.
Richard, did you have?
So, what this means is that sometime in the next year or so, the CQC is going to put you guys in a room and grill you. So the question is, what help and support do you need in order to make an informed representation?
Well, yes, I was going to say it wasn't so much diplomatic, it was almost a bit threatening, you know. What do we need? You know, the headlight, the spotlight in your face. I mean, it's a very good comment you made, Gary. Originally, my understanding was that they were going to avoid the one-word statement. But actually, as things have developed and continue to develop, it will be that one word. And of course, the danger with that is what will get picked up by the media. That not only is, I mean, I'm hoping, you know, that we're not at the red end or the orange end, shall I put it that way, But for those authorities that are, it's the impact that has on the morale of your staff, the confidence that users of your services have, and the third thing is your ability to recruit. And that's always the danger of an oversimplistic headline approach. So it is regrettable, but that's the way they've gone. As people who have in education, all the NHS knows that they've had to live with it, but I don't think it is particularly helpful. You know, particularly in areas of recruitment. You know, we've done a joint workforce strategy, which is being rolled out. But services like ours, however much you use digital, which we can, it's still a hands-on people-to-people service. So, you know, it is one of those things. But to reiterate Richard's comments, you know, a frank assessment of, you know, if the CQC asks to speak to you, whether you feel confident or not, or whether there's other information you may need to be able to give that feedback, you know, good or bad, at the end of the day, you've got to give an honest feedback, which is important.
Following on from that, Amanda, like they certainly do across the children's world, will there be like a self-assessment done? It's quite often when you're being inspected, one of the questions is what you see your own issues and stuff. Where they always say, don't they? Do you know yourself? So I just wondered whether that would be something that would be a self-assessment, and whether that could be shared and give people an insight beforehand, or whether that's something will just be kept internally.
We have drafted a self-assessment, and we continue to update it all the time, because the self-assessment has to be within the last 12 months. So we are constantly updating whenever a letter might fall on our desk. And when I'm going to be around speaking to partners at the moment, I'm testing that self-assessment we've done of ourselves to attest whether there's things that we need to learn more.
No, that sounds good approach. Any other comments? No. If there's nothing else, then Amanda, thank you very much for that. And then we'll move on to the next item, which is JS&A development. Emma, thank you.
Sorry, do you want me to start? So I'm just sorting out something because I've got a little bit of a demonstration for everybody, so bear with me. This is really just an update from the last time I was here, which wasn't that long ago. I think it was the last board, to talk about how we've moved this forward and looking at how we're developing the JS&A. So since the last time I was here, we've set up our steering group, which has got representatives from all the various organisations, so health, district and borough councils. I think Stoke come to that as well, so it's quite broad. So there's a number of different people on that, and that group has got people who are working at different levels. So it's not just the technical people who would work on the sort of data side of things. That also includes people who are working in different services or different areas that might want to help shape this going forward. We've also had our first working group meeting that's going to meet more regularly, and that is more technical people or people who've got a sort of specialist interest in a particular area, and that's really to shape the content of some of the information that's going to populate the JS&A. I can share with you a slide in a minute of how some of that process works. So the initial chapters, and I think I might have mentioned this last time, are going to focus on a life course approach. So we'll have a look. The first one will be things around population and demographics, then starting well, living well, and ageing well. So it'll be easy for people to read. It'll follow on like chapters, if you see what I mean. So if you can imagine what the existing one was like in a PDF, it will almost be following on that kind of form, but more electronically and able to do a bit more with it. So, because it's really a very complex piece of work to pull everything together, we need to complete this in phases. So we're starting off with the demographics one. The real reason is because it's easier to get a lot of the data for that. It's mainly open source data or stuff that's published that could be pulled through. But when we come on to the later chapters, we'll be able to add more information from different organisations or the kinds of things the different working group would recommend populating that for what they need. So we've to date done a detailed mapping of the data requirements for the first chapter, which looks at collating all the different indicators, different sources, the various dates that they're up to, geography, that kind of thing, so you know what level the information's available at. This takes quite a lot of time because we look at what there is out there, what there is in our existing piece, and then what else other people think to collate a sort of master file. That's really, really important that it's done thoroughly. But that's happened so far. And we've also started doing the Ageing Well section, kind of in anticipation of some of the work that's coming up with the CQC to help support that. So that will be the next chapter we do actually after we do the demographic one you know, so when the CQC come in, we've got more information on that, and then we shall work through the rest. So we've started mapping on that front. So the working group will be able to scrutinise all the different information and indicators, make sure they're accurate, make sure they're correct. And because those people have got the expertise in the subject area, they can, you know, if there's any concerns with something or there's something that is missing, that's the point when people can tell us and help make sure that it's as robust as possible. I accept that not everybody knows every single thing, so we need to make sure we get the best advice possible, really. And so once we've done that, what we were going to propose was, we've got the life course sections done, is we're going to try and make a systematic approach to what other chapters we're going to add. So this is where we'll probably go out to all our various partners and say sort of what are the key issues, collate sort of a response, and then identify some key things to do some more in-depth bits of work on. So I know in other areas they've done stuff on housing, some places have done cost of living, just depends what in that area is having an impact at the time. So I think the first full chapter should be ready for October, which will be the demographics one, and hopefully the next time I'll be able to bring back something that will show that, and we'll be probably well on our way of doing the Ageing Well stuff too. I don't know, can I share this up on the screen? I'm just going to share this quickly. Can you see this is just our process basically? I'll try and put that up big. Does it come up? Oh. There we go. I mean, it's not very clear to see this. The writing's really, really small, but it just really shows what I've just spoken about, really, how we select the different chapters and how the information is sort of collated, goes via the group, and everything's added. So what I'll do is I'm going to share something else, which is the actual first sort of demonstration of the work that's been done. So that really we've had a lot of help from Lindsay and Julia, who's doing the analysis on this, and she started to pull the first few bits of data through. So if I just go on and share, I can show you, this will help visualise it a little bit, and I think that is probably easier for people to see then. Can everybody see that here? Yeah, okay, cool. So this is basically like how you'll have a title sheet for the JSNA. So, for example, the population demographic one. And it's just got a table of contents in there. Bear in mind, it will be much more populated than this. This is really just to demonstrate a few of the bits of data to test that the feed can come through and everything. So this isn't looking anything like it will when it's finalised, but I just wanted to show people how it was progressing so far. So, for example, if you click on life expectancy at birth, it takes you to these charts, so you can track along. And I think this is Staffordshire compared to sort of statistical neighbours, so local authorities that have similar populations and geographies, that kind of thing. It looks a bit bare at the moment, and there's a reason, because we'll have maps and things on this where you can click on different areas of the map and it will help reshape trends and pull up different tables and stuff like that. But really, I just wanted you to see how functional it is. So you can make the maps bigger if you want to have a look. You can export them to use in reports. If you see at the bottom where I've gone on to this disability-free life expectancy, this is where the sort of descriptor of what the indicator says and what it means for Staffordshire and that kind of thing will go in. So hopefully that gives you an idea of how it will progress. And please don't think it's going to be like this. It won't. It'll be much better than that. It's just, I said last time I would try and bring something for people to, get an idea of how it will function, and that's what I've done this time. So now that all the mapping's done, that chapter can be built up, and next time I'll be able to bring something that looks a bit more whizzy, and at least you've had a chance to see the sort of how it's developing in its infancy. If anybody has any questions, that's, I think.
So thank you very much, Emma. Thank you for that. So, as before, any questions anybody'd like to ask? Okay, in that case, thank you very much for that. And just one on time scale. Then, when will it be? When do we anticipate it be completely complete, or at least a?
Okay, so I thought the JSNA is probably never really complete because it's constantly got to be updated, and as I mentioned, there'll be different priorities to form more, I guess what we would call a deep dive of information on a particular topic. We're aiming to have that chapter, the first one I mentioned, October, and I think I'm hoping that we have the older adults one and some of the life course stuff done by December. That's sort of our key deadline. Obviously, it may need refining and bits and bobs to go in, and depending on how the working groups go as well, because it's not just dependent on us. We have to get a consensus and everything and check governance and that. And then after Christmas, what I was hoping to do really that's when maybe poll the different partners about what sections they think would be key to having additional chapters on, areas of priority across all the systems. And then start building those as well. We've also got quite a lot to do with this in terms of upskilling staff and things, so there's actually a lot more going on behind the scenes than just us trying to get information. It's a lot more complex than I'm describing probably. Does that help? So December's kind of what we've set as to get the main sections done, or at least have some of the majority of those populated.
Okay, that's great. Thank you very much. Oh, yeah, of course you can.
Yes, thank you for that. I mean, I appreciate there's a huge amount of background work goes into this. But I think in terms of health and wellbeing boards and people around here, of course, one of the key questions is, what is this data telling us? Is there something, I mean, a bit like the CQ2C discussion, it's what you don't know or you haven't picked up, which needs flagging up to us. So, when do we get to the point where actually there are some, headline indicators that we can either assure ourselves that actually that issue is being picked up elsewhere, or actually there's something here that is new that we're not aware of and we need to take into consideration? Because to me, that's what it's all about. It's not producing a very detailed, comprehensive database. It's actually flagging up there's something here we've not picked up on before and we need to start looking at it.
Yeah, no, that's a good point. I think the way the working groups have been set up to involve people who've got, knowledge and not just data knowledge, but knowledge about the particular areas, that's how we will decide indicators that we know are things that are a priority in Staffordshire. And from that, I think, we'll measure those. And I've asked, because I didn't go to the first working group, the people who are helping, so I'll go to some of them. What I would like people to really think about with that is not just necessarily things where it looks like we're not doing as well, because sometimes those aren't all they seem, but also things where we think we've got a downward trend, or something that wouldn't, necessarily flag up as being a concern, but we know there's additional issues around that. And then we'll have a suite of indicators in each chapter with all the charts and tables, the ability to look at the geographies, if depending on whether they're available at what level, if you see what I mean, and governance obviously. But yeah, so that's what we have in mind, to make those chapters as representative of what we need to be doing in Staffordshire, yeah.
Emma, thank you for that. So the screen just disappeared. The board is asked to support the development of the JS&A 2023 and note the timescales for the development. And I'm sure everyone's happy with that. Okay, so Emma, thank you very much. We'll move then on to the next item, then, which is the Better Care Fund. Roseanne, thank you very much.
It's the simple things. Okay, so in terms of the Better Care Fund plan, since the last board, the policy framework was published, and this required that Staffordshire submit our plans by the 28th of June, which we have done. We had to complete a narrative plan, an expenditure plan, capacity and demand estimates, and the usual ambitions for BCF metrics. So in line with the delegated approval, this was approved by Julia and Mark. All existing schemes were rolled forward because much of the Better Care Fund actually goes towards funding core services such as contributing towards home care, residential care, reablement, etc. So we rolled forward all the existing schemes. We actually expect to hear by tomorrow if ours has been approved, but we've heard that the regional assurers have recommended approval, so that's hopeful. In terms of the actual money, I've included a summary, table 1 of the funding allocations, and you'll see that the DFG allocations and the IBCF allocations remain the same. The NHS minimum contributions increased by over 5% each year, and the Council and the ICB Adult Social Care Discharge Grant allocations actually increased by over £3 million each year, which is great. Now, in terms of that grant allocation, we are required to agree how we spend it between the Council and the ICB, which we have done. We've proposed our schemes, we had a bit of negotiation, and we've agreed them all. And you'll note that there's also a contingency in there so that we've got some money left should we need it. Have included a note in the paper about the ICB allocation because they get their allocation in a lump sum for Staffordshire and Stoke, and then it's agreed locally how this is apportioned out. So it has come to our attention that it isn't split fairly at the moment. It's not consistent with the adult population across Staffordshire and Stoke. So this means that over the next 2 years, we're down by about £900,000. So we have written to them to say we'd like this reviewed, which they've acknowledged. And we've agreed to review this over the next year through our joint commissioning board. So we're hopeful that this we're able to redress the balance. Now, in terms of the wider Better Care Fund, so talked about the plans, they've been submitted, but we're making a few tweaks to the Better Care Fund Section 75 this year. So, for example, we've got a range of contracts between us and health that aren't in the Better Care Fund, and we've got lots of different agreements, and they finish on different dates, and we've got different working groups, etc. So, to streamline the approach, to streamline the contract monitoring, so that it can all be through our joint commissioning board and the Better Care Fund, we've agreed that we've got a handful of agreements that we will try and put in to the Better Care Fund Section 75 this year. For example, at the moment, the Council have a 256 agreement with the NHS where we commission health tasks on their behalf. So it makes sense because we're already commissioning home care, that if somebody has a bit of a health need as well, then we will commission them on the NHS behalf. And what we're saying is actually it makes sense to include that in the Better Care Fund so that it's performance managed through the same group. And in another example, we're doing the same for Section 117. You're probably aware we have an agreement for a 50-50 share on cost, and that's a separate agreement again. So as with the health task one, we want to put it all into the Better Care Fund through one contractual agreement. So we're currently sort of redrafting our specs. As soon as they're done and approved, we hope to update our Section 75, and then, as I said, that will massively streamline our contracting arrangement and actually be beneficial so we can performance monitor all the agreements through one board. So that is the very brief update from me, other than, sorry to add, they have commenced regular reporting, so we're reporting fortnightly on the Better Care Fund grant, which is a little bit painful, and I believe a lot of local authorities have fed that back, and we're awaiting feedback as to what it's being used for. We don't currently know, but yeah, that's the brief update for me. Are there any questions?
Any questions for Anna? Okay, in that case then, there are the recommendations A to D, which I'll run through fairly quickly. The board is asked to note that the 2023-25 BCF policy framework was published in April 2023, which required the submission of the plans by the 28th of June. Plans are expected to be assured today by the 8th of September. B, note that the plans have been submitted, including narrative plan, expenditure template, capacity and demand, and ambitions and delivery plans for the BCF metrics. C, note that expenditure plans for the 2023-24 and 24-25 SCC and ICB adult social care discharge grants have been agreed and are detailed within this report tables 2 and 3. And lastly, D, note that the current proportion split of the ICB ASC discharge grant to each health and wellbeing board area is not consistent with the adult population of the ICS that the council have requested that the apportionment of the ICB's ASC grant allocation is reviewed to redress this balance. Okay, so we'll take that as read without any comments. So Raja, thank you very much for your attendance. I'm sorry you had to wait just a little bit longer than you probably expected. Which means we move on to the next item on the agenda, item 7, Health and Wellbeing Board Strategy. For that, John.
You'll be pleased to know it's a very quick one. It was just really to alert the board, to remind the board actually that for the 4 strategy priority areas, we do have a set of metrics. The paper there has a web link to those metrics and it is updated on a quarterly basis. It's really just to remind people that's the case. Clearly we'll link that into the JSNA as that develops, but so people are aware of those metrics. I just want to make sure that was there. And I think the paper, it says, it also makes reference to an added metric in there around referrals to secondary mental health for young people. So it was just really to kind of update the board, make sure you're aware of that.
Okay, thank you for that. Does anyone have any comments on that they'd like to raise at all? Any questions? No? Okay. So let's go back to the agenda so I get it right. Let's have a look. So the next item on the agenda as published was right care, right person. Staffordshire Police not been able to attend to date, but I do have an assurance from them that at the next Health and Wellbeing Board in December that will send an appropriate representative who will be able to detail the work that's being done on that area. Some of you may well have been invited and attended one of the sessions, engagement sessions they've been running. I know myself, I have, and Julia has, and Neelam, I know you have. So I don't see much point in discussing that in any detail today without a police rep here to be able to answer to any of the points. But I would be interested from an ICB perspective to know whether you've been to any of these sessions at all, if you know whether you've been involved at all.
Yes, we have attended the partnership briefing events and ensured that a number of our providers are attending. We have a mental health LDA programme board where Right Care, Right Person is going to be focused on in terms of that partnership arrangement. So we've got an away event, I think in either later this month or early October, where again partners from the local authority are invited. Our chief exec sponsor, Bucky Adamo, and Ben Richards, who are SRO, have run those invitations, and we're going to have a focus session there on Right Care, Right Person. We are pleased with Staffordshire Police's approach, which has been very different to a number of other police forces in the area, and that they're taking a very collaborative approach with us in terms of the phasing and the timescales around the different elements of the partnership agreement that's been issued nationally. So we'll make sure that we continue to engage with our local local authority partners as part of that partnership approach to how right care, right person is delivered.
So Nicola, that session that you spoke about just, has that been initiated by yourselves, or is that something the police have initiated?
So that's been initiated by ourselves, the Mental Health LDA Portfolio Board, and obviously as part of the discussions that we've had. So there was a discussion that was had with Peter Axon, who's our Chief Exec Officer, as well as Chris Bird, who's our Chief Transformation Officer, and Ben Richards, who's the Senior Responsible Officer for that Portfolio Programme Board. And the request was made there that we take this approach. They're going to present, and then we'll have a sort of focused workshop in terms of how we respond to that national agreement that's been issued.
Okay, so perhaps if I can put a little bit of explanation around this for people that might not understand. Right care, right person is as Nicola mentions, is a national framework put together by Home Office and Health and Social Care, Health and Social Care centrally, that they wish police forces to adopt. And that's about, as it says on the tin, trying to get the right person to attend incidents around mental health. And it was piloted in Humberside for about three years, and it's slowly been rolled out around the country. And I think I'm right in saying that across the country there has been different levels of engagement with partners. The national agreement specifically states that it doesn't use these words about co-production, but in fact it talks about all the partners being involved in the development, and that's certainly from a health and wellbeing board and from adult and social care perspectives are keen to ensure that everyone is involved in that development. So look forward to that session you spoke about, and also listening to what the police have got to say on our next meeting in December. Any comments at all?
One of the services that it could have significant impact on is the ambulance services. Have they been engaged through your process? Unfortunately, the session, Gary was present as well, and Neelam, that we attended, unfortunately there wasn't a representative there from the ambulance service. And, they, like all services, they're under pressure. But I think I haven't seen the data that the police have, but obviously they've got quite a detailed analysis of the calls that need to be diverted. So, I think one of the key service partners is going to be the Ambulance Trust. And, I'm just anxious to make sure that they are involved.
So you're absolutely right. So the potential impact of this is quite significant if it's not considered in the sort of co-produced collaborative way that we've spoken about. So, you're right, Councillor Sutton, there's some areas of the other parts of the country where we haven't had this sort of considered approach. So absolutely, all of our partners will be absolutely key stakeholders in this, including the West Midlands Ambulance Trust. As an ICB, we have also, one of our priority areas is around improving improving the ambulance response around people with mental illness and mental health issues. And we've actually been working in partnership with WOMAS to deliver that objective, and again working with our other regional ICB areas as well. So we have invested quite significantly in terms of that improvement. So additional education and training for paramedics, specifically around people with mental health issues, making sure that there's the clinical professionals are available within the control unit, essentially, that dispatches the ambulances. And we will have what's called a mental health response vehicle that will be delivered by WOMAS, that will be available, obviously, to Staffordshire and Stoke-on-Trent residents. So it's part of a wider picture around how we respond effectively in terms of emergency care around people with a mental health issue. So it's definitely high on our priority agenda in terms of how we do that, to make sure that we ensure we meet the needs of our residents across the population. So there's a number of different parts that we're building up to that will help support the implementation of the national agreement over the next sort of 2 to 3 years.
Yes, I mean, obviously police do have a lot of data, but we've not seen it. And we don't know whether that is really from the police perspective or partnership perspective. And in the spirit of really wanting to make whatever new system is work, I did make the suggestion whether we could trial it in Staffordshire as well, because they're not looking to implement it till February, but actually just to get a feel as to how the system here would respond and what the issues might be. Because I'm sure they're telling the truth, but I just want to see it from our partnership perspective and, our citizens' perspective, rather than what's been tried. And yes, we do learn from other places, so I have no issue with that, but still wanting to be sure as to how it will work in practice here.
Aileen, thank you for that. Okay, in the absence of any other comments then, thank you very much for that. We move on to the next item on the agenda, which is the forward plan.
Jonathan, I'm just picking up on Neelam's comments. I just wonder, in the absence of the police, whether we could actually reiterate that request that we could, or key partners can be assured that they will have a demonstration of how this system is going to work before they go live in February, isn't it? Would you as chairman be prepared to do that?
Nick, I was just thinking, when is that day that or that session outlined for?
My laptop's just decided to crash on me, so I was just desperately trying to have a look, but I will get that to you. I think it's early October in terms of that session. But just to be clear, in terms of the February date that you've referenced, that is specifically the safe and well checks that the police do. So that isn't the whole of the agreement, which obviously would be a really significant change. But you're right, Neelam. I think it's about it's about us all having the shared understanding of what that information is and actually being able to sign up to it, isn't it? So if you would like, Councillor, I can request our SRO for mental health and LDA request that information if that's something that you would be interested in.
I think I would. I mean, having an assurance from the police that they would meet with us before the date in December to strategic level, so we could go through some things. I'm keen that there's not lots of duplication and everybody's meeting with the police separately. It seems to me would be better to do it all at once. But you are right, Nicola. There are 4 go-live dates, aren't there, that they've got at this moment in time. February, May, August and November of next year, and the whole thing split into 4. And the first one being, those welfare calls. Perhaps I can consider that what Julie said when right back to the police to try and arrange some dates. But I'll wait on when you've got this session. So I've got some ideas of that. And I've also been in touch with the Local Government Association, and they've got people who are working, doing some research around that. So, and I've got some best practice as well that they've got from some police forces around the country, which I'll happily share with you as well. So it might give a little bit of a pointer and ideas where it's working or not working in other parts of the country.
Not a problem. Very quick one. In terms of the forward plan for the next meeting, we've got mental health priority on that agenda. We've got, well, now we've probably got right care, right person as well, actually. Adult safeguarding, and probably bring the JSNA back, actually, because I think that'll, Emma was suggesting that would be at a point where it would be nearly finished, so I think it'd be a good time to bring that back.
I do think we have to be a little bit careful on the agenda, only from the point of view that if we do discuss a right care, right person thing in some detail, it's going to take up probably a little bit of the agenda, isn't it? So just mindful that we don't, put too much on there. Okay. Before we close, then, any other comments from anybody on anything at all from today, or anything that they feel that ought to be on a forward agenda, the forward plan? No? Okay. In that case, can I thank everybody for their attendance and see you hopefully all at the next meeting in December.